Now we move on to the next session, the role of imaging in strabismus. Imaging has become the norm in most of the subspecialties now, and there are situations where you need to image some of the complex strabismus situations. So I call upon Dr. Aungshi Filasaman to talk on the role of imaging in strabismus. She is a pediatric ophthalmologist, did her fellowship in Comtrust Eye Hospital, and she is a pediatric ophthalmology consultant in Aradhana Eye Hospital and Geethanjali Eye Hospital in Eye and ENT Center in Trivandrum, and
Shankar's.
In Punalur, she is the pediatric consultant ophthalmologist. Over to Dr. Aungshi.
I would like to thank my mentor, Dr. Laila Mohan and KSOS for giving this opportunity to me. The topic that I was given is the role of imaging in strabismus. When I was first given this topic, I told madam that there's nothing to say about this. We all know it's imaging. I have very less things to say. But when I actually started reading up on it and doing more things on it, that's when I realized you need 8 minutes for each topic that I'm going to talk about. But I'll try to make it as short as possible and easy so everyone can understand. So what is the importance of imaging in strabismus? I would like to begin by talking about this patient of mine that walked into my OPD last year with the complaint of occasional face turn to the right side. The mother says that for the past 2 years, the child has been very clumsy and falls down a lot while playing. This was how the child was sitting in my OPD. On examination, the child had mild limitation of abduction of the right eye, and the child was not cooperating for PBCT, prism test. So on account of the acute onset of strabismus, I sent the patient for neuroimaging and pediatric neurologist's opinion, and I lost follow-up of the child for 8 months. When the mother and the child came back after 8 months, this was what the mother had to say. On the imaging table, while MRI was being performed, the child had an epilepsy episode, and the imaging could not be completed. A very short video was obtained from where it was found that the child had optic brainstem glioma. And the child was taken to Sri Chitra, and treatment was taken for there. In the past 8 months, the child had received 31 doses of radiation, and it was explained to the patient that the chances of recurrence are very high. Child is on remission right now, but on regular follow-up. And this is how the child came to me after 8 months. So, coming to imaging, MRI remains the mainstay for surgical planning and diagnosis of strabismus. We usually go for MRI of orbit with fat suppression to assess the orbital soft tissue and extraocular muscles. 1.5 to 3 mm cuts in the coronal plane is preferred. It helps to improve visualization of extraocular muscles. When to consider MRI, like I've demonstrated before, acute onset strabismus, complex strabismus, any nerve palsies, and if we're suspecting any neurological issues. It helps us to assess the anatomy of the extraocular muscles and connective tissue, and also if there's any problem in the intracranial visual pathways and identify inflammatory vascular neoplasms. Also helps us to identify various orbital abnormalities, which I will not be going into detail. When we get an MRI report, these are the things that we have to look for. Number one step, we have to make sure that the patient's head and gaze position during image acquisition, that is the interhemispheric sulcus, aligns with the vertical scanner of the machine. Step 2, we have to find the relative location of the extraocular muscles with respect to center of the globe. The third step is that we have to look for asymmetries between the two globes. Like I said before, it helps to detect brain abnormalities. Periventricular leukomalacia, as it was said yesterday, is one of the most common causes of strabismus, and sometimes nystagmus and strabismus may be the only presenting symptoms for kids with periventricular leukomalacia. In pattern strabismus, in A pattern, lateral rectus may be displaced upward, and V pattern, lateral rectus may be displaced downward. Understanding this helps us to realize that it is not because of oblique dysfunction, but because of and helps us to change our mode of surgery treatment. Even in superior oblique palsies, it can be either absent or it can be paretic, as Park's three-step test in various studies have shown that it's only 70% sensitive. It also helps to differentiate between heavy eye syndrome and sagging eye syndrome. As in the first picture, we see that in heavy eye syndrome, there is a prolapse in the superior temporal quadrant of the globe, and the lateral rectus is placed very adjacent to the globe, and it is displaced inferiorly. Whereas in case of sagging eye syndrome, there is no prolapse of the superior temporal quadrant. That place is occupied by lacrimal gland and fat, and the lateral rectus is displaced away from the globe. So this is how it helps to differentiate between heavy eye syndrome and sagging eye syndrome. The other benefits of MRI is that radiation exposure is very less. It can be easily performed in cooperative patients, but it does not provide much valuable information in case of concomitant esotropia. Neither can it help us to measure the limbus insertion value, contraindicated in claustrophobic patients, and then we need special training for that. The other thing especially limited in our society is that it is expensive, so sometimes the parents are very reluctant to do that. The next imaging is UBM. It has 50 megahertz and it has better resolution than the conventional B scan, which has 10 megahertz. Helps us to find out the exact insertion of extraocular muscle and distance from the limbus. We put a speculum and the transducer is held tangentially over insertion of the muscle without putting the cup. We use a gel instead. Oscillations perpendicular to the limbus to obtain an axial cross-section of insertion, and the globe is held in AB duction for medial rectus muscle and AD duction for lateral rectus muscle with a fixation forceps. This is how the image will be obtained, and the area where we hold with the caliper will be seen as a shadow. We measure the distance from this caliper shadow to the muscle insertion, which can be seen as a potential space located between the global surface of muscle and sclera. Various studies have been done to compare the pre-op ultrasound measurement with the intra-op caliper measurement, and it has been found that all the measurements were within 1 millimeter of each other. It was very reliable in patients with prior strabismus surgery in case they don't have any records with them. Also decreases the risk of intraoperative complications like excessive manipulations, which causes bleeding and more scarring. It has better resolution and higher image quality. The limitation is that it can detect lateral rectus only 50% of the time, so sometimes it may not be as useful as we thought it was. And it can detect, the further the muscle is away from the limbus, the detection becomes more difficult. And it is easier to detect in case of resection as compared to recession, because recession leaves behind pseudotendon, which can be detected as false insertion. Sometimes there is overestimation of measurement. Since it's a contact procedure, sometimes the patients may not be very comfortable, and depending on the gaze, the measurement can also vary. The last one is anterior segment OCT. It has spatial resolution of 10 to 20 micrometer and works on the principle of low coherence interferometry, measures the echo time delay and intensity of backscattered and back reflected light. For this, the patient is seated, anterior segment biometry protocol is selected, and 15-degree temporal gaze for medial rectus and 30-degree for lateral rectus. This is how the image will be obtained, and then we can see that this is the root of the iris. We measure from the root of the iris till the insertion of the muscle. In this, we have measured, there is the lateral rectus. The measurement comes as 5.44. To this, we add 1 millimeter because from the limbus of the limbus till the iris root, it's considered approximately taken as 1 millimeter. Various studies have also been done by our very own madam, who is Elizabeth madam, who has been sitting here, and 88.6% were within 1 millimeter difference, so it was found to be very reliable for those undergoing surgery for the first time. The benefit is that it's easy to perform, it's non-contact OPD procedure and highly accurate. The limitation is that we have already assumed that the measurement from the angle from the limbus to the iris root is 1 millimeter. We are not all different. There may be variations between each individual, and that can cause systematic error. So it's also difficult to detect in those with slanting extraocular muscle insertions, which may be congenital or from previous surgeries, and also difficult to differentiate between normal insertion and abnormal adherence. In conclusion, we can use imaging to help us better plan our surgical approach for optimal results, and also helps to rule out neurological issues which may be life-saving for the patient. So our main aim is to correlate our clinical findings with the imaging results and make decision. I would like to make a disclaimer that I have no financial interest and I do not own the images. Thank you.
Thank you, Dr. Aungshi, for that wonderful talk on imaging. Now, we go to the keynote speaker. There is no need for introduction of Dr. Sumita Agarkar from Shankar Netralaya. She is the HOD of Pediatric Ophthalmology Department there and the Joint Secretary of Strabismology and Pediatric Ophthalmology Society of India. Over to Dr. Sumita Agarkar for a difficult topic, management of strabismus in thyroid eye disease and imaging too.
Yes, talking about thyroid is easy. Managing it is difficult. So I'm only talking, so I think it's not that difficult. So thyroid eye disease or thyroid orbitopathy is acute, basically a clinical spectrum of clinical disease which has involvement of muscles, optic nerve, orbital tissues, as well as even the ocular surface and cornea in the later stages. But if you look at the muscles or strabismus point of view, we have two clear phases in the whole disease spectrum. You have acute inflammatory phase with a lymphocytic infiltration and congestion of the orbital tissues, which can lead to pain and sometimes diplopia and ocular movement limitation, for which the patient come to us for that. And then there is a chronic phase where there is a adipose tissue infiltration and fibrotic changes in the extraocular muscles, leading to tight and fibrotic muscles, leading to a restrictive strabismus. So it is almost, strabismus is seen in 17 to 51% of the patient depending on the racial population. Fortunately for us in India, we don't see it that often with thyroid eye disease the way it is reported in the Western literature. The risk factors which are associated for strabismus are age. Middle-aged patients are more likely to have than younger patients. Women have more represented in children in strabismus with thyroid eye disease. Smokers, definitely, because smokers with thyroid eye disease are twice likely to need strabismus surgery compared to non-smokers. And definitely family history of thyroid eye disease, sometimes that also plays a role as a risk factor. So this is how a typical patient might look. Here it is difficult to assume which eye is actually fixing because both the eyes have severe disease. But you can see there is proptosis, there is limited ocular movements, though I can't make out from this picture, but there is proptosis, there is lid retraction, there is strabismus. You can see almost the entire spectrum of thyroid eye disease in this patient. So basically it's a autoimmune disease, as we all know, and leads to lymphocytic infiltration, edema, and then leading to increased orbital volume, proptosis, and increased intraorbital pressure, and ultimately at some stage leading to fibrosis and restrictive strabismus. It is also influenced by genetic and environmental factors, genetic factors like family history and environmental factors like smoking. So this is a patient, as you can see, there is right esotropia in the primary gaze, but there is restriction of abduction in both the eyes. So it's slightly asymmetric involvement, but medial rectus both sides is likely to get involved. He also has, you can see elevation limitation in both the eyes. So if you look at the muscles, this is the frequency of muscle involvement. Inferior rectus followed by medial rectus is the most common presentation. But do not forget that occasionally even obliques can be involved and you have to look for it. Why inferior rectus? Because probably it is the bulkiest muscle which is and it is tonically very active muscle. So that muscle is probably most likely to get affected in thyroid eye disease. So what are the investigations? You would look at thyroid function tests. You will, from strabismus point of view, diplopia and Hess chart. This helps in monitoring the disease. And post-duction test, which is the most important test, which you have to do it before you do anything surgically in these patients. And of course, imaging. The STIR or short tau inversion recovery way of imaging is very, very helpful in outlining the disease activity, because this focuses on the water content of the muscle and suppresses the fat. So you can see activity of the disease very nicely in this kind of imaging, and also delineates the muscle involvement and optic nerve compression. CT orbits and ultrasound can have a limited role. So in the imaging you can definitely see fusiform enlargement of the muscle bellies here, and you can also see there is strabismus. So these are the differentials, and each of them can, sometimes myasthenia gravis can coexist with thyroiditis, and you must keep the possibility in mind. Inflammatory conditions like myositis and orbital inflammation can mimic thyroiditis, and sometimes even the space occupying lesions of the orbit which can affect multiple cranial nerves can also look like thyroiditis. So management of strabismus is basically divided into medical management and surgical. Medical management involves keeping the thyroid eye status of the thyroid in control, radiation therapy if required, botulinum toxin for small angle strabismus, and prisms will go through it one by one. So prisms can be used as Fresnel or ground-in prisms depending on the angle, and it is definitely, you can give it as a definitive treatment for small angle deviation, but if the angles are large it can be only a temporary treatment while waiting for strabismus to stabilize. Botulinum toxin, there are very few reports, but poor surgical candidates which cannot be treated with prisms, botulinum toxin has been tried, and Dr. David Granett has written a lot of his experiences have been published. Only problem here is downside is recurrent injections and difficulty in precisely delivering, because orbits are tight, bulky, and sometimes it is difficult to really deliver the injection where it is supposed to go in the muscle belly. Now surgical indications will be intractable diplopia on primary gaze or in down gaze, abnormal head position, and if it is cosmetically very disfiguring strabismus, then definitely you need to do something. What are the challenges? Outcomes are likely to be suboptimal. Muscles can be very tight and fibrotic. There is incompetence. Sometimes the angles are different within the gaze itself. Like you will have angles, hypotropia of 30 here and 25 here and 20 here, and then it's very difficult to plan surgery for these. So your surgical dose calculation becomes complicated in view of severe incompetence. So here you have to spell out your surgical goals very precisely. It is impossible to make them single and make them aligned in every gaze and everything. So you have to clearly tell it to the patient that you are going to achieve just enlargement of the binocular single vision field, and we are going to probably look at practical gazes, which are the primary position and the down gaze. So surgical dose calculation is because nomograms do not apply in these conditions. So the dictum is a lot gets you little and little gets you a lot. So smaller angle needs larger recessions and larger angle needs smaller recessions. Timing of the surgery you have to do in active stage when the disease activity is least, which can be determined by your orbital colleague or on imaging. If orbital decompression has been planned, then strabismus surgery is best done after that, because it can alter the strabismus, at the same time can produce new strabismus also. So orbital decompression, if at all everything has to be planned, it has to be only after decompression. Stable measurements for at least 6 months, and as I said, your MRI can also help you to decide when is the quiet and the disease is quiet. So most common surgery which we do is recession of the tight muscle. Resections are better avoided, but there is, I just found this article published in 2017 where as a second procedure, if you have got residual, you can plan for small resections, and they have reported good results, although the N is just 10, but probably as a second procedure or for a small angle remaining residual symptomatic patients, you can look at resections also. So adjustable sutures, there are two schools of thought here. Some people advocate adjustables, some people say that adjustables lead to late overcorrections, and which is probably true in the cases of inferior rectus recessions, where adjustable sutures using adjustable suture probably leads to late overcorrections. Non-absorbable sutures are preferable compared to the absorbable one. So this is what you need to counsel the patients, that you may need multiple surgeries, you may have subnormal or suboptimal outcome, and and there may be surgery can actually increase the proptosis as well as late retraction. So when you plan for surgery, preoperative consideration should include primary, secondary and tertiary actions also. You should know how to get rid of torsional action by moving the vertical muscles or moving the horizontal muscles, and you should keep that in mind when you're, because the less you do is always going to be the best. So fusional range consideration, so always leave the previously hypotropic eye with a small hypo, don't make it hyper, because that patient can become very, very uncomfortable. Keep the ocular torsion as a factor when you're planning surgery, and a lot more times FDT is far more informative than imaging in these conditions, especially when surgery is being planned. Intraoperatively, just perform ductions. Forced duction test is essential before and after the surgery, and also after the conjunctival closure. In large muscle recessions, you also should plan a small conjunctival recession, because sometimes conjunctiva can produce a tether of its own. Dissection has to be very neat, and particularly around inferior rectus, so that lid retraction worsening can be avoided. So as I said, adjustable is a little bit of a controversy. There are enough people who are on two groups. I personally don't do adjustables in thyroid eye disease. I use fixed suture, and so as I said, key concerns with adjustable suture would be muscle slippage, scar elongation and progressive overcorrection, which is fairly commonly seen with inferior rectus. So intraoperative, you have to be prepared for a very tightened muscle, which can lead to pull-in 2 and a friable and shortened conjunctiva. So you need to have some special equipment like a double Kowal hook, or a forceps which has these kind of blunt edges to hold the conjunctiva, because conjunctiva is very friable. There is another technique which you use is intraoperative relaxed muscle technique, where to decide how much recession you should do, because in these cases your normal surgical nomograms don't apply. So basically you disinsert the muscle and let it slip back, and wherever it rests you suture the muscle there while you hold the globe in the primary position. And Del Canto et al. Have reported good results with this technique, and this usually is self-adjusting, and you can probably get good outcomes out of this. So as you can see, sometimes less is more. This patient has a very significant hypotropia, but just with one muscle recession, just an inferior rectus recession, you have got a fairly good result in this patient. So these are the complications, and late overcorrections are known. These are the methods by which you can prevent the late overcorrections of inferior rectus recession, because late overcorrection can give rise to diplopia in the down gaze, which is patient will complain. So this is a serious problem when you are trying to do the surgery. Again, A pattern exotropia is fairly common, and that can be little bit obviated if you are doing to do with bilateral inferior rectus recession. You can just shift the patient medial rectus inferior rectus can be medially transposed by half tendon width to reduce the exotropia, but this transposing the inferior rectus medially also gives rise to torsion, so you have to be a little bit careful about this nasal transposition of the inferior rectus. So summarize, surgery only if it is cosmetically quiescent stage, do a conservative therapy, give attempt for all, and do talk about lifestyle changes to the patient. And standard surgical nomograms are not applicable, so you may have to plan as you go along during the surgery. Thank you.
Thank you, Dr. Sumita, for making an elaborate, giving a talk on a tough subject, thyroid eye disease. And strabismus in thyroid is always difficult to manage.
Thank you, Dr. Sumita. Next, next talk is by Dr. Satish. He is talking on upshoots in Duane's retraction syndrome. Dr. Satish Thomas is the head of the pediatric ophthalmology department in Believers Church Medical College, Tiruvalla. Over to you, Dr. Satish.
Thank you, Dr. Laila, for giving me this opportunity. My topic is a simple one, just on the overshoots in Duane retraction syndrome. As you know, Duane's retraction syndrome is a cranial dysgenesis, disinnervation disorder, where there is congenital agenesis of the lateral rectus nucleus, and the lateral rectus is supplied by a branch of the medial rectus, and therefore this causes co-contraction on adduction, and she finds it difficult to move it into adduction. There's a quick upward movement. It just quickly moves up and disappears. So coming to the overshoots in adduction, they can be upshoots or downshoots, and Stephen Kraft classified them into either mechanical or innervational. The mechanical one is due to co-contraction of the lateral rectus with slippage of the globe above or below the tight lateral rectus. It is called a leash effect. And the innervational type is believed to be due to aberrant innervation of the vertical or the oblique muscles along with the contraction of the medial rectus. And this is usually found in Duane's type 3, but it can also be found in the other types like in the one we saw here. So how do we differentiate the two? The mechanical type, there is an abrupt upshoot or downshoot in adduction, and there is no vertical deviation in the primary gaze. Whereas in the innervational, it's more of a gradual upshoot like that you see in an inferior oblique overaction. And sometimes a vertical deviation can be present even in the primary gaze. There are some MRI studies which show minimal vertical displacement of the lateral rectus and increase in size of the vertical muscles, suggesting contraction in adduction in the innervational type. The majority are mechanical, as shown by Kavan Mohan and group from PGI. Ramesh Kekunya and all from the LV Prasad, they have come up with a grading system if you want to grade this upshoots. So you can grade it by drawing a horizontal line parallel to the intercanthal line, bisecting the pupil in the good eye, in the eye which is not in adduction, and then seeing where it lies in the adducted eye. Can we play this video? So, regarding the child with the upshoot, what I did here was a Y split of the lateral rectus. So Y split of the lateral rectus is being done here. Lateral rectus is isolated, and then it is split in the center before disinsertion. And then the two separate limbs of the lateral rectus are secured separately, and then it is disinserted. So that's the muscle being split into a Y at its insertion, and then you reinsert it back, splitting the Y widely. So the upper limb is secured at the upper margin of the original insertion, the lower one at the lower insertion. If you want, you can combine this with a little bit of recession. I haven't combined it with a recession in this case. It's not moving. So you can see that when you secure it, you will get a Y-shape pattern to the insertion. You can see the lateral rectus having that Y. So this, once it is inserted like that, then the globe cannot slip above and below the lateral rectus, and that is how it takes care of the. So here's the post-op video. you can see that in adduction, the globe is retracting, but the upshoot is gone. There is still limited abduction, but on adduction, you will see that the globe retracts, but the upshoot is gone, and so it takes care of that cosmetic defect. In inferior oblique myectomy has been proposed in the innovational type. Marshall Parks reported very poor results, but Avadin has reported good results on 11 patients of his. Thank you for your patient here.
Thank you, Dr. Satish Thomas, for that very nice presentation. What I usually do is always I combine recession with this Y-split, and I split it for a much longer, as maximum backwards. That will produce less. Now now I request the next topic, please.
I think the next one.
Dr. Laila's talk next.
Or you can have your talk. Yes?
I will do it. Yeah, I can. Or I can let the third no palsy talk be there. I will present that first.
I would like to introduce Dr. Elizabeth Joseph, Madam. She is the HOD of Little Flower, Angamali, and she was the first doctor in Kerala to start pediatric ophthalmology department in LF.
Good morning, everyone. I will be presenting about the role of imaging and the challenges we face in the management of third nerve palsy. So you all know that third nerve nucleus is situated in the midbrain. It has got various subnuclei. The Edinger-Westphal nucleus take care of the pupillary fibers and the ciliary ganglion, and that is the central caudal nucleus, that is a single midline nucleus that innervates both levator palpebrae. And the superior rectus nuclei supplies the contralateral superior rectus. Whereas medial rectus, inferior rectus and inferior oblique nuclei supply the ipsilateral eye. So in a nuclear paralysis, there will be bilateral ptosis and opposite eye superior rectus. With the same eye, medial rectus, inferior rectus and inferior oblique. That is how you localize whether it is a nuclear lesion or not. And coming from the nucleus, the fascicular portion goes through the medial longitudinal fasciculus, the red nucleus, substantia nigra, and then emerge from the midbrain in the interpedunculaire fossa. So as the third nerve passes through all these structures, there will be associated neurological findings like ataxia, hemiplegia, etc. in case of fascicular portion involvement. Then it travels through the cavernous sinus, superior orbital fissure, divides into superior and inferior divisions, and then innervates. So in all these places, the third nerve may be involved in different pathologies. The various imaging modalities, the primary imaging modality is of course MRI, because of its high soft tissue contrast and ability to show the entire course of the third nerve. MRI sequences used besides T1 and T2 weighted images is the diffusion weighted image. MR angiography is done if you are thinking about a vascular pathology. CT scanning has got limited role. This is important if you are suspecting an trauma, skull fracture and all. Digital subtraction angiography is reserved for cases in which cerebral aneurysm or carotid cavernous sinus fistula is suspected. See, now I will show you the picture of some of the images in the patients. See, this is a right posterior communicating artery aneurysm. You can see this is demonstrated in the MR angiogram, and then the T2 weighted image showing thickening of the aneurysm pressing on the third nerve. Then coming to another patient, a 57-year-old male presented with the left third nerve palsy and weakness of bilateral superior rectus. Bilateral incomplete ptosis. That was a nuclear lesion, and you can see a rim enhancing lesion, and that was a midbrain metastasis. Another patient, 53-year-old female, presented with incomplete third nerve palsy, contralateral ataxia. This is the ischemic infarct. So these are all neurological findings and will be managed by the neurologist. And this is a patient with a Toloso-Hunt syndrome, the painful ophthalmoplegic syndrome. Imaging shows thickening and involvement of the cavernous sinus and even the dura. Now coming to the clinical features of third nerve palsy, as we all know, patient presents with a ptosis. The eye will be fixed in the down and out position, and there will be exodeviation. Like in this patient, ptosis is there, eye is fixed in abduction, and there is defective depression and elevation. You have to think about that in third nerve palsy, as in any other cranial nerve palsies, the basic principle is that a good neurology workup imaging is a must, and wait for 3 to 6 months for recovery, and after that, if there is no natural recovery, then only do the surgery. A word about pupil sparing third nerve palsy. Isolated third nerve palsy with a normal pupillary function is more or less benign, and it's usually due to ischemia seen in conditions like diabetes and hypertension. In pupil sparing third nerve palsy, if there are no other neurological symptoms, you can give a good prognosis and can give conservative management. Most often that will recover. And those cases which is not recovering, then we have to think about the surgical management. And the surgical management of third nerve palsy is the most difficult for the strabismologists, because the results are not always very satisfactory, and the management depends on whether it is a complete palsy or incomplete palsy, and whether there is the presence of aberrant regeneration. See, look at this patient. He had this patient had an intracranial tumor presented with a total third nerve palsy with ptosis, and in such conditions, what will you do? When the eye is open, you can see the eye is fixed in abduction, and in such cases, look for some action of the medial rectus by force generation test. If there is some action of the medial rectus, supramaximal recess resect surgeries will work. If there is no action of the medial rectus, we have to think about transposition procedures. There are superior oblique transposition to medial rectus, which is a very difficult procedure because it involves dissection at the trochlea. LR transposition to the medial rectus is now advocated with a fairly good result, but that again is a difficult procedure. Periosteal fixation to the lateral rectus, globe anchoring procedures, these are all done with more ease and a good prognosis. In isolated palsies, things are easier. If it is a superior oblique palsy, you can put the two horizontal muscles upwards as in the NAP surgery, or you can weaken the elevators of the opposite eye. In inferior rectus palsy, you can have ipsilateral superior rectus weakening, contralateral inferior rectus weakening. MR palsy, if there is some residual action, recess resect. Inferior oblique palsy, if associated with superior oblique overaction, weaken the ipsilateral superior oblique and contralateral superior rectus. Now let us see some real conditions. This is a complete third nerve palsy with total ptosis. The patient was having an intracranial tumor which was operated, and we took care of the ptosis by doing the frontalis sling, and we did a large recession, supramaximal recession of the lateral rectus with a globe fixation to the medial orbital wall. This globe fixation, what I did was just like a DCR incision, put an incision there, expose the medial palpebral ligament and expose the periosteum, and then put a non-absorbable suture through the medial palpebral ligament at the periosteum, which was then brought out underneath the conjunctiva, and then the medial rectus area was exposed, and the suture brought out through the conjunctiva, sutured to the sclera at the level of medial rectus insertion. That is how you do it. It's a little time consuming, and but it has got a very good result. This is the 2 weeks post-op picture. Supramaximal recess resect is a very good procedure. See, in this patient had a road traffic accident, presented with a large exotropia. The pupil recovered, and the patient had see this primary position exo, and on attempted levo version there was no movement of the medial rectus, -5 limitation of adduction. So in that case, ideal thing may be a lateral rectus transposition to the medial rectus, which is a very difficult procedure and is met with complications. So I just went and did the supramaximal recess resect procedure. See, supramaximal recess resect of both eyes has improved the condition, but there is a still there is a residual exo. And on abduction or levo version, the adduction, the eye has come to the midline, not much adduction. And the patient was happy with this much of improvement, and I didn't do anything further. If you want, there is a risk of exotropic drift again. If the exotropic drift occurs, we can do a globe fixation. See, medial, in such a condition, the other alternative is to do transplantation of lateral rectus to the medial rectus. And that is a very difficult procedure, but this is a patient, the report by Dr. Rohit Saxena et al. Published in British Journal of Ophthalmology. Patient presented with a primary position large exodeviation with the absence of abduction, and they did a muscle splitting of the lateral rectus and transplantation of the lateral rectus to the medial rectus. You have to split the lateral rectus as back as possible, and the upper part of the lateral rectus has to be brought underneath the superior rectus, superior oblique, towards the medial rectus, and the lower half has to be brought underneath the inferior oblique, inferior rectus, to the lower border of the medial rectus. And it is their result, according to them, it gives a very good result. The eye will be immobile, but in primary position it will be straight, and the binocular field of no diplopia will be brought to the center. So this is an effective surgery, but is met with complications like a choroidal hemorrhage, and the surgery is very difficult. Yeah, in such a case, supramaximal recess resect is enough. And when there is an aberrant regeneration, things are different. See, this patient has got a ptosis, the eye is fixed in abduction, and when the patient is adducting, the eye goes, the lid goes upwards. So this is due to aberrant regeneration. The fibers which are destined to go to the levator muscle is supplying the medial rectus. So this is aberrant regeneration. This can be tackled by resection of the medial rectus, recession of the lateral rectus, and then a superior rectus recession of the opposite eye to tackle the aberrant regeneration. See this postoperative result, good result. So when there is an aberrant regeneration, you tackle accordingly. And what about ptosis in third nerve palsy? Frontalic sling, it can be done, but remember that if there is no Bell's phenomenon, there is chance of corneal exposure. If there is a superior rectus is partly recovered, you can do opposite superior rectus weakening. Levator resection can be done in partially recovered cases. And in aberrant regeneration, I have already discussed. Crutch glasses can be given in such conditions. Thank you very much for the patient hearing. Thanks all.
Next, I would like to introduce Dr. Laila Mohan. She is my dynamic mentor, and Over to you, madam. She is the head of department of Comtrust Eye Hospital, Calicut.
Thank you, Dr. Angushi. So now we move on to a next condition, a complex strabismus where we need an imaging to decide surgery. Myopic strabismus fixus or strabismus fixus convergence and heavy eye syndrome also as it is called is an acquired esotropia with hypotropia seen in high myopia of usually more than 15 diopters and axial length more than 27 millimeters. And there is progressive ESO and hypotropia which fixes the eye in adduction, and abduction and elevation is limited. And traditionally, recess resection were used to be done, which is ineffective and may even aggravate. So proper surgical planning with imaging is important to address the pathology. And pathophysiology is unique in this case. So Huguenot first described in 1969 this condition, and he believed it to be due to structural changes and fibrous tissue in lateral rectus. Bagolini in 70s explained it by myopathy of lateral rectus due to pressure on the lateral orbital wall due to a large eyeball. And a long eye, the eye going in and down due to gravity playing a role, gave the name heavy eye syndrome. And Demer and Van Ouden in 1989 showed the restrictive nature due to the posterior part of the eyeball being in contact with the orbital apex. And by MRI, with the advent of high resolution MRI in 1997, it was Krzyzok who showed that there is progressive prolapse of the staphylomatous globe into the posterolateral quadrant of the orbit between the lateral rectus and superior rectus. And this was the basis for Yokoyama surgery in 2000. So after this MRI, high resolution MRI, the treatment modality has changed completely. So coming to the MRI findings, there is progressive protrusion of the globe through this defect, and orbital connective tissue ligaments between the lateral rectus and superior rectus degenerates and thins out, and the coronal sections in front of optic nerve globe junction about 9 millimeters in front of it shows the actual pathology, that is inferior displacement of lateral rectus, which weakens abduction and converts it into a depressor, and nasalization of the superior rectus, which weakens elevation and converts it into an adductor. Thus the esotropia and hypotropia. So you can see here there is what we call the globe dislocation angle between the lateral rectus and superior rectus. It's about 100 degree in the normal individuals, which increases to almost 160 or even more, and can be assessed before and after surgery in these cases. The differentials are sagging eye syndrome as shown by Dr. Aungshi. There is degeneration of intermuscular septum, and soft tissue prolapse is there, and lacrimal gland also, but no prolapse of the globe. And though there is Graves' ophthalmopathy is another condition to be differentiated, of course, by imaging again and history. And long-standing sixth-nerve palsy sometimes confuses us when it is bilateral, especially. Myasthenia, when it is long-standing and untreated, can occasionally confuse with this condition. And often clinical examination is diagnostic, and history of high myopia with a long axial length and MRI are diagnostic. So there are, so coming to the surgical management, more important than reinforcing the action of muscle by recess resection is the normalizing of the anatomic path of the recti to prevent globe prolapse. And suturing of lateral rectus, superior rectus 15 millimeter behind limbus with non-absorbable suture was suggested, which gave good results. And partial Jensen's muscle splitting and reunion of muscle belly, which also in some cases proved to be useful and gave a good outcome. And some of the modifications were suturing it at 2-3 points, because one suture does not hold enough, and because the distance between the two muscles are also big, and sometimes cheese wiring also can occur. So a hemi-transposition of the superior rectus and lateral rectus with scleral fixation at 7 millimeters from the insertion was proposed by Yamadas. All these gave some good results, but not all cases, and this unites the muscle pulley and pushes back the herniated eyeball back into the muscle core. And studies are there with and without scleral fixation, with or without medial rectus recession, after doing a force reduction test if the medial rectus is tight, and Botox injection and medial rectus recession can be contemplated because when 3 muscles are tackled, there is a risk of anterior segment ischemia. So the modified silicon band loop myopexy is now somewhat universally accepted because the suture technique has the risk of cheese wiring because the muscles are very tight, and the anterior segment ischemia is also there, risk of anterior segment ischemia. You can see when you hook the superior, it is completely medially, the superior rectus is nasally displaced. That is the behind the superior rectus, there is a risk of catching hold of the superior oblique, which you can see there. And lateral rectus completely displaced downward. There is a large distance between the two, especially when it goes, the muscle is traced backwards. You can see it is displaced backward. And with loop myopexy and medial rectus, it gives very good results. And there is no risk of cheese wiring and breakage of sutures as in suture technique of myopexy. So with the silicone band, either you can take it through a tunnel in the sclera, or after suturing you can fix it also into the sclera. So and you have to fix the muscle well backward behind 8 to 10 millimeters behind the insertion. So choosing the procedure according to the angle, most of the studies are done in East Asian countries. We don't see the strabismus fixes that often, and they have suggested that partial Jensen's procedure works for angle of prism between 30 to about 120 prisms when done bilaterally, and Yokoyama's procedures up to 40 prisms, and Yokoyama procedure with recession of medial rectus in cases from about 15 to 90 prisms of esotropia. And these are some of the newer techniques where there is a surgical interlacing. You split half of superior and lateral rectus, and the lateral rectus is taken through the superior rectus medial half, lateral half, and then suture it back to the insertion so that there is no chance for prolapse of the globe through the space between the superior and lateral rectus. So there are some complications. Histopathological examination of the eyeballs from patients have shown ocular ischemia and atrophy of optic nerve or CRA occlusion. So due to the mechanical stretching and torsion of the optic nerve with subsequent strangulation of blood supply. So early correction of strabismus fixes is recommended. So to summarize, myopic strabismus fixus has a unique pathophysiology due to the elongation and staphyloma of the globe, can be definitively documented by MRI or CT scan. The surgical approach is specific to this condition, and reunion of muscle bellies gives good results. Thank you.
Thank you, Dr. Laila, for that very nice presentation on loop myopexy. I have one question. Is there any chance of extrusion of this silicon band?
I've had very few cases, 2 cases, they are doing very well. And silicon band I have found even in superior oblique spacer, when I have used for Brown syndrome, they don't produce much of a reaction or extrusion. I have never had one. Thank you.
Any chance of recurrence of the same problem?
Actually, in one case, we had a medial rectus recession done in childhood in this lady, which she was not aware of. She presented after 50 years, and she had presented with a large esotropia. So if there is force reduction test is positive, and if there is no way you can tackle the medial rectus, sometimes it can produce some undercorrection, but some amount of esotropia still gives good results for the motility of the eye, and the patients are very happy.
Yes, I think our time is over. We will conclude the session. Thank you all for a very patient hearing. I thank all the speakers for very nice presentations.